I'm delighted to be talking about postpartum hemorrhage today, and it's quite an exciting time for postpartum hemorrhage. There are a number of new data, particularly for uterotonics for prevention, and there seems to be accumulating data that tranexamic acid may also be useful for prevention of PPH at caesarean section in addition to uterotonics. Just like before, I think we've really got to focus though on when in the management of PPH, we need to really think about getting help early, particularly where transfer is going to be required. Teams should be familiar with their local PPH algorithms and their box or trolley. Really start thinking about weighing all blood loss cumulatively to ensure better recognition and therefore action on the PPH. We need to escalate early for senior help. Document all of the actions on your local PPH performer, and let's have a think about, okay, how should we debrief parents and the maternity team after the event itself. So I think we all know that postpartum hemorrhage is the leading cause of maternal death worldwide. It accounts for 20% of maternal deaths in developing regions, 8% of maternal deaths in developed regions, and if you look at the UK data, 9% of maternal deaths were due to PPH in the Embrace 2016-2018 report. The incidence of PPH is actually increasing right across the world. In the US, PPH rate has gone up fivefold from 8 to 40 per 10,000 births from 1993 to 2014. And across Africa, there's been a reported tenfold increase. And I think if we're really going to focus on this, it's prevention and early, accurate management of PPH remain the key strategies to reduce both mortality and morbidity. So what are the recent recommendations? Well, there have been some really important recommendations in the Embrace report, and there are 5 main areas of concern for UK practice, and I think could be applied in many different settings across the world. PPH prevention remains a key strategy. But let's also, when we're talking about management, recognize women's blood volume, particularly how for women with a lower BMI, smaller women, lower blood volumes may impact more on their circulation because it's a higher proportional blood loss. Also remember that maternal anemia, even at levels less than 100 grams per litre, the maternal anemia increases the risk of PPH, but it also increases the effect of PPH. There are so many women now on prophylactic and treatment dose anticoagulation in our care. We've just got to think about a proper management plan, antenatally, intrapartum and postnatally. And as always, it's early cause-specific treatment of the PPH before the onset of coagulation and severe shock wherever we can. So let's think about prevention. Well, what's new in the active management of the third stage of labour? Okay, there are definite benefits to cord clamping after at least 60 seconds post-birth in all births, caesarean birth, vaginal birth, instrumental birth, preterm birth, term birth. It's really important to wait at least 60 seconds. There are big benefits to the baby in particular, and seem to be benefits in early childhood too. There's no advantage to controlled cord traction, therefore you can use it or not use it. So really what it means is uterotonics are key. Now, if you look across the world and sort of think, well, why in very high maternal mortality settings where prophylactic and therapeutic oxytocin are available, which is widespreadly available, then it may be they're less effective due to the poor quality of oxytocin with generics and also the heat stability. There have been 3 really important studies of uterotonics for vaginal birth over the last year. In the IMOX and Champion studies, both confirmed that intramuscular syntocinon and carbetocin are equally effective to prevent PPH with similar side effects. IMOX identified there were advantages in reduced additional uterotonic use with symptometrin, but there were significant disadvantages, particularly side effects, and particularly with early bonding with the baby. The labour study from Dublin demonstrated advantages using intravenous syntocinon compared to intramuscular, but clearly there are issues with rapid use of high dose oxytocin that can be problematic. The WHO has said, look, there's no clear best option for PPH prevention of vaginal birth, and what they've said is, okay, use either IV or IM syntocinon or carbetocin where the cost is comparable to syntocinon. Interestingly, at caesarean section, there seems to be more evidence that carbetocin is useful, and in fact there's been a really important recent international anaesthetic consensus that recommends IV carbetocin as the primary oxytocic. Now, in addition to oxytocics, if you have a look at the TRAP study and the TRAP2 study, there seem to be advantages to use of prophylactic tranexamic acid, 1 gram IV at caesarean section, but less obviously the benefits of vaginal birth. So when we come on to management, let's think about our current care. The EMBRACE study clearly identified we use too little, too late. Too little in the terms of IV fluids, blood and clotting factors. Too late with the use of prostaglandins, adequate resuscitation, and senior support and decision for surgery. We often delay the decision for surgery for reasonable reasons, but sometimes it's just too late. And the final thing that I think to help us understand how to improve giving fluids and blood factors, improve our response to PPH, is we should weigh blood loss. And that's been associated with higher reported rates of PPH because of improved recognition of PPH. The management of PPH, as always, requires a systematic approach with useful cause-specific treatment, including early escalation to the multi-professional team, assign team members to record the events, record the fluids, the drugs, the blood components, and all the vital signs. Certainly in our service, many services, I think the use of a pro forma and an algorithm really helps us provide the best possible care. Let's make the right way the easy way. Let's use Muse charts. Let's think about fluid replacement and blood products proportionate to blood loss and the woman's body weight. Tranexamic acid should definitely be given early alongside additional uterotonics. It's sometimes useful for the senior clinician just to take a helicopter view of the management and coordinate care. So I always think, let's just stop for 20 seconds to plan the next 20 minutes. Where are we up to? Where have we got to? Okay, this is what we're going to do next. I think point of care testing has been really helpful to understand and focus our coagulation assessment and treatment. And as I said before, early decision for surgical management is really, really important. So early recognition, let's definitely use Muse charts. Let's help ourselves identify cardiovascular compromise early. That really helps us identify the deteriorating woman. We can then act on the signs and symptoms, and definitely monitor the fundal height postnatally, because bleeding can be concealed. So if a woman appears to be deteriorating with no external blood loss, then consider whether or not the bleeding is concealed. Quantifying blood loss. There's a well-recognized association that estimated blood loss is often half what the real blood loss is. So we may be artificially reassured, and I think it's now becoming, easier to weigh the blood loss rather than guess how much you think it might be. We use dry weights. Now, of course, once the baby has been born, there shouldn't be any more liquor coming out. But so therefore, it's really important to change the swabs and drapes and pads after the baby's been born to reduce the risk of excess measurement. But after that, I think it's really useful just to measure the dry weight of the sheets and swabs and pads in the baby scales, and that helps us understand how much blood loss has been lost. Think about the maternal weight. I think, look at, for a woman who is 50 kilos, can you see she would lose 30% of her blood loss at 1500 mils? Whereas actually for a woman with 80 kilos or 100 kilos, that wouldn't even be 15%. So you can understand that women, small women, may be disproportionately impacted by the same blood loss. I think that's a really important key message. Proactively treat. So let's take a systematic approach. you've got to think about simultaneous resuscitation and cause-specific treatment. Escalate early. Replace the fluid, the blood, the clotting factors, and as I said before, really helpful at each stage just to stand back for 20 seconds to plan the next 20 minutes. PPH and algorithms, emergency boxes, I think really, really important. Make sure they are evidence-based, make sure they're accessible, and make sure you use them during your training so everyone understands how to use them and where they're actually located. First thing, call for help. Get the PPH trolley in, get the right people in, allocate the team roles, and have a think about, do you need to activate the major hemorrhage protocol, which for us is, at or heading towards 1500 mils. ABC, lie the woman flat, consider high flow oxygen, definitely try and get some uterine compression, put 2 cannulas in, get the bloods done, start IV fluids in both arms, and start thinking about point of care testing, ROTEM or the TEG. Do your primary assessment, checking your observations, weighing the blood loss, check the placental membranes, and then start thinking about, okay, what's the cause here? Is it the tone? Is it retained tissue? Is it trauma? Or are there clotting problems giving rise to thrombin issues? Then stop the bleeding. For atonic loss, then think about a ladder of treatment, oxytocin infusion, carbaprost, misoprostol, but give tranexamic acid early and always put in a urinary catheter. Coming back to tranexamic acid, we know from the woman study published a while ago now that a significant reduction in maternal deaths, but it has to be given early and definitely within 3 hours. It's essential, just like always, to treat the cause and consider early transfer to theatre for bleeding that continues. So have a think about uterine atony. Think about massage, catheterized bladder, give you standard uterotonics we already discussed. Empty the uterus, then that clearly is going to require an examination under anaesthetic, plus uterotonics, and check the placental membranes. Repair tears, and observe closely for cumulative blood loss during suturing. And I think even if you're repairing a tear in the room, it would be worth giving tranexamic acid for a continuing bleed from a perineal tear. Check for coagulopathy and treat appropriately. I think that's more of a consideration once you've gone to theatre. And as always, this is all about teamwork and practice to manage this effectively and efficiently. Interruptive cell salvage. This is, as we all know, blood collecting during surgery, filtered and washed. It's increasingly being used, and I don't think we should confine it to women who refuse blood products or just where there's a placenta previa or placenta accreta where we're thinking there might be massive blood loss. The salvo studies are reassuring, and certainly in our service, it has really almost eliminated transfusion post-section. There's some very interesting early data on vaginal collection that's promising, but it's not currently recommended for clinical practice. Point of care testing, I think, is becoming increasingly accessible and increasingly useful. It's really useful to guide transfusion management, to reduce the delay, obtaining results for both the full blood count and clotting. Hemagu provides a hemoglobin estimation very rapidly, but remember, before fluid resuscitation, it may be artificially high, or people can be reassured artificially. Arterial and venous blood samples really helpful to understand serial effects on pH, base excess, and lactate. And ROTEM or TEG, both of them provide real-time coagulation that helps us guide treatment coagulopathies in case of massive, rapid hemorrhage. So check the clotting, including fibrinogen. Don't wait for the results, just get on with the clotting factors if required. Really important to keep the woman warm. It's using blood warmers and also warming blankets. And the point of care testing informs whether or not to give fresh frozen plasma, cryo, or other areas such as platelets. People have used factor 7A, but that should only be used after consultation with a consultant hematologist. Now, after the PPH, it's really important to proactively plan the management post-event. continue to weigh the blood loss. Use ongoing and repeated assessments, and I think it's really important, maybe have a think about using the critical care module to help you plan your HDU and critical care on the labour ward. Have a think about team reviews, post-event planning, your documentation, and the team debrief.